on e-health and digital transformation in healthcare. I think it is the future, and I hope we will have the opportunity to open a bit the discussion after our talks, but I know we are running a bit late. Now I would like to present the next speaker. This for sure I will pronounce well. It's Professor Alfred Gatt from the University of Malta, Faculty of Health Sciences, who will be talking about the future of podiatry in Europe, together for a better profession.
So, good morning again. Normally I would be here presenting our latest research. I have a lot of that going on, and we're very excited, but I decided to take a step back and look at podiatry as a profession, because I think that as podiatrists we highly underrate ourselves, and maybe we feel that because maybe we look at the feet, because there's the paper actually about this, about people, podiatrists looking at the feet and dentists looking at the head. There is a paper, and I think we are very important. And I would like to bring diabetic foot as an example, okay, on the importance of podiatry. So if we look at this study, which looked at trends in amputation in 1990 compared to 2017, you'll see that the trends have remained the same. Amputations have not decreased significantly, okay? There are some areas where amputations have even increased slightly. And we're talking, a 27-year gap, 27 years, And basically, I think that the podiatrists have a very potential impact on doing this, on getting this, making it better, and reducing these trends. Okay, so as you can see, more or less, they are the same all over Europe. Podiatrists are very important in the multidisciplinary team when treating the diabetic foot, okay? And as studies have shown that the intervention of the podiatrists have resulted in some countries in some reduction in trends, in amputations. This is a paper that came out last year. It wasn't done by podiatrists, actually in Malta, where I come from, and where they realized that 60% of the amputees had not been to a podiatrist. Okay? So the vascular surgeon who led this study, thinks that it is one of the main reasons why these people have these amputations. So each member of the multidisciplinary team has specific skills. I'm sure you all agree. The diabetologist will have specific skills, the physiotherapist will have specific skills, the vascular surgeon has specific skills, and even the podiatrist. We must not forget that as podiatrists, we have a lot of skills that other professions do not. And I think we should focus on that more. We should elaborate on that more, and we should increase the competencies, the level of competencies that we already have. Okay? We all know that as podiatrists, the basic skill is to do a detailed examination of the foot. The management of so-called minor foot conditions. A minor foot condition, a simple hammer toe, will cause an ulcer and will cause osteomyelitis, amputation. But I've seen podiatrists. I've seen Alfonso. Let me. Yeah, he's the guy who's going. Do an extensor tenotomy in 3 minutes. And that's the amount of skill that, as a podiatry profession we have. I mean, you're telling me that most of us cannot do an osteotomy, but anatomy, yes, but it is part of the profession. There are other things that we can do. Start off, vascular examination. We know issues with vascular examinations. We know how to read the Doppler, hopefully. I mean, that should be one of the most basic skills of any podiatrist. We know the problems of using ABPIs, ankle brachial pressure index, and that's why most of us should use TBPI or waveform analysis, where we have shown that Doppler waveform analysis with trained podiatrists is very, very, very reliable. Had a reliability coefficient of about 0.9, above 0.9. Neurological examinations, isn't this something we do as well? And aren't we aware that neurological tests might produce different results? Okay? But if we had to have other practitioners doing these tests, they might not be aware of the problems. Like ABPI, I might have a patient with an ABPI of 1 and have arterial calcification, but if I am not trained as a podiatrist, I would not realize that that 1, which denotes a perfect circulation, no? In a patient with PAD would be 1 because of calcification. Why? Because, yeah, I wouldn't have the competences of a podiatrist. What about biomechanical skills? Well, at least that is one of the, common areas in podiatry. And offloading diabetic foot, areas of at risk of ulceration, applying our biomechanical skills to design offloading devices. Not only that, because a large percentage of patients with, I'm using diabetes only as an example, because it's not only diabetes, okay? But we know that the most glamorous area where we can, use our might, sort of, is in diabetes, okay? Where diabetes, because of, the deposition of glucose in the soft tissue, will produce a lot of changes, okay, in the structure of the foot. And these so-called minor conditions need to be treated. And this is one of our earlier studies where we found that, look, actually about almost 50% of our patients had hallux valgus in Malta. And these were patients visiting a regular health center. They were not high-risk patients or anything like that. Even diabetes itself, that diabetes itself, the duration of diabetes, increases plantar pressure. So we all know how to look at plantar pressure, how to evaluate plantar pressure. And as Kevin, Professor Deschamps, had mentioned earlier, there are now guidelines, like more than 200. Okay, if it's more than 200 kilopascals, you need to look at it. In our case, our patients with no deformities at all, but having a longer duration of diabetes, we had an average of about 350 kilopascals in these healthy diabetic patients without deformities. So we see that even diabetes itself raises the loading on the foot because, again, of the deposition of glucose in the soft tissues, which makes them stiffer. Yeah. For us, how many of these do we see? A GP refers a patient like this, eats a simple corn, go to the podiatrist, and boom, you find not 1, 2 ulcers on the apex of the toe. you know. It's something that we can manage so well. And we know that even a simple, what we might call a simple amputation of just one toe is just the beginning. And then the second toe, and then the third toe, and then the part of the foot, and then the foot, and so forth. And we know how to apply biomechanical concepts to these patients. And most importantly, we know how to offload them. And not just offload them, but measure and see how effective our treatment is, okay? And measure again to make it even more effective. We have the skills using in-shoe pressure mapping, for example, you know, to do this. Obviously, advice on footwear is so important, no? Good shoes. How we're in the best position to advise good shoes. And I might have some people who wear tight shoes. Oops. Tight-fitting shoes, all these tight-fitting shoes that my colleague is wearing there. It's disgraceful, but anyway. Now, why am I saying all this? Obviously, podiatry is not just foot ulcer care. There is rheumatology, there is podopediatrics, podogeriatrics, clinical biomechanics, sports medicine, orthosis, a lot. And even new emerging topics like forensic podiatry. That's an exciting new one. Or emergency podiatry. You know, how many emergency departments do you find a podiatrist? No one. No? But you find a physiotherapist to treat your foot problem, the patient with a foot problem. You'll find a physiotherapist to treat that. So, to come back to my original title, you'll say, what does all this have to do with the title, you know? So, I was looking this morning at the associations, the countries who are in FIP. And there are 23 members of FIP, I found out this morning. And there's like Belgium, Czech Republic, Denmark, Finland. Sorry, I can't see it because there's a reflection there. I don't know which country this is. Fédération Nationale des Podologues. France, no? France, yes. Germany, Greece, Ireland, Italy, Malta, Norway, Poland. You'd be, how do you say it? Say like, how come there are even associations of podiatry where there is no podiatry? Like, for example, in the Czech Republic, and I think also in Poland. Okay? So, the dentist, I always say this, is a dentist. Wherever you go, a dentist is a dentist. Okay? Once I had an argument with a very well-known diabetologist who was saying, you know, maybe you have a podiatrist and you have a lower grade of a podiatrist and then you have a lower grade. And, you know, I told her, do you have a mini dentist or a mini dermatologist or a mini, you know, a podiatrist is a podiatrist. Nothing mini, nothing less. And then you have this minimum level. And then from there you can go up, you cannot go down. Because we cannot let our patients be treated by professionals. If they are professionals, these professionals shouldn't be of a lower quality because we say, oh, no, but it takes too long to train a podiatrist. It takes a long time to treat a dentist. And without removing any important, I mean, if my tooth falls off, well, I can do another one. But if my foot has to be amputated, that's for me, that's... Okay, so more or less the competences of podiatrists over Europe, and it's the majority of the members of FIP, right? I think there are about 17 countries in FIP out of 23, all over the world, okay? Our competencies, and maybe it's up to us as the teachers here, mostly, right? To make sure that the competencies that we teach to our students are of the highest level, and we make sure that the competencies are more or less the same all over Europe. Common training framework, we've talked about common framing. We've worked for a common training framework for a very, very long time, okay? 2017, we met in Paris, 2018, we went to Brussels and we said, wow, we're going to do it now. But I think realistically, it's almost impossible to get. And there's your new president there. She was doing a presentation about Enpodhe in Brussels in 2018. Yeah, you can remember. I think up to last year, we had talks with ECP, with lawyers in Brussels, just to make it happen. I think it's a very big problem. But why? Because each country has different health laws. Okay? And the European Union cannot dictate to that country what health laws, any changes in the health law. I mean, they can do pressure, but I don't think, following some meetings we had with some MEPs about how high they prioritize the movement of podiatrists in Europe, because they said, for us, it's not a problem because no podiatrist has ever complained that they cannot work in another country. So please start complaining. That's what we told him, Look, physiotherapists complain a lot, so for them it's a priority. But podiatrists, it's not a complaint, because we said, that should be a basic principle of being able to move freely from one country to another. So currently, there are these two bodies that offer recognition. First is the Royal College of Physicians and Surgeons of Glasgow, and now there is the ABPMI, the American Board of Podiatric Medicine International, who are setting up exams, okay, so that European podiatrists can do this exam, and so you'll be a diplomate of the American Board of Podiatric Medicine. It does not make you a DPM. It does not give you the right to work in America. But they saw the value of this to come to Europe and offer some kind of measurable, level which everyone can look up to, and they say, look, an exam by ABPMI is a really high exam. And even the Royal College of Physicians and Surgeons of Glasgow, it's a very, very old institution. You can be a member or a fellow. Oops. But why do we need to wait for these people to do this for us? And my case here, as I put it to my colleagues yesterday, maybe this could be one of the functions of Enpodhe. Enpodhe, where we've done so many conferences, where we see students working together. I think this was in Brussels, if I'm not mistaken. Our in Brussels, where we enjoy so much, our Enpodhe meetings. Why should not Enpodhe work to become the new level which can set exams, which can be followed, which can be taken by European students, not students, after they've graduated, of podiatry? We know we set a level, the Enpodhe sets a level, not a very low level, but, a good level, because the Americans, they don't really know, and I've seen some of the questions, they don't really understand what podiatrists in Europe study. For example, one of the questions was, you have a patient with a bullet wound in his foot. Bullet wound? I've never seen a patient with a bullet in his foot in 35 years. But in America, it's okay because they're always shooting each other, you know. So this could be, you know, one such example. One such examples. Remember that the future of podiatry lies in the hands of teachers, of us, but I put it in a bigger font. It lies in the hands of our students. Because tomorrow, they are going to be the practitioners, and they are going to be the teachers again and again and again. So we hope to set something solid, a solid foundation, so that our students can work on these solid foundations and build up something which we would be very proud of. Thank you very much.